nye metoder and priority setting in the specialist healthcare service. Hi, I'm Michael Vester, and in the next 30 minutes, I'm going to talk to you about nye metoder, which is a system for prioritizing on a group level within the specialist healthcare services in Norway. I work in the Secretariat for nye metoder as a medical advisor. My background is many years of practice as a family and public health physician, and I started working with nye metoder from the very beginning in 2013. I have been asked to talk about nye metoder as a system for managed introduction of new methods in the specialist healthcare services in Norway. I will refer to this as nye metoder, that is new methods in English, which is the official name for the national system for managed introduction of new methods in the specialist healthcare service. In this presentation, I will focus on the system, its background, how it's organized, and how decisions are made. Although I understand that others are going to talk to you about priority setting, I will briefly talk about that since it is the foundation of everything we do. At the end, I'll give you a short introduction to our website, nymetoder.no. Background. Systematic efforts relating to prioritization issues in the Norwegian healthcare services go back decades. In the past 30 years, 5 government commissions were appointed to evaluate principles for priority setting in the healthcare sector. The Learning 1 Commission in 1987, the Learning 2 Commission in 1997, the Grund Commission also in 1997, and the Norheim Commission in 2014, and the Magnussen Working Group in 2015. In the official report 1997-18 Priority Setting Revisited, the Learning 2 Commission recommended that priority setting in the Norwegian healthcare services should be based on 3 criteria: severity, expected benefit, and cost effectiveness. Parallel to this, in official report 1997-7, Pills, Priorities and Policy, the Grund Commission recommended reimbursement of costs for medications to treat serious diseases when such medicines are proven to be beneficial and cost-effective. Benefit and cost-effectiveness were directed towards the objective of achieving the best possible health in relation to available resources, while severity was directed towards the objective of providing medical assistance to those in the greatest need of it. The proposal of the Learning 2 Commission defining the 3 priority setting criteria, severity, expected benefit and cost effectiveness, was approved by the Storting in its deliberation on report number 26, 1999-2000 to the Storting on values for Norwegian healthcare services, and has since formed the foundation for priority setting. The Norwegian Patient Rights Act incorporates these criteria. The Grund Commission's recommendations resulted in the addition of Section 14 to the Norwegian Act on Medicinal Products, which regulates medicines funded by the Norwegian National Insurance Scheme. In 2013, the National System for Managed Introduction of New Health Technologies within the Specialist Healthcare Services was established. This was mainly due to differences in practices for introduction and decision-making, and the need for making systematic and informed decisions on a national level. The national system, nye metoder, makes funding decisions for medicines and technologies used in the Norwegian hospitals based on the priority setting criteria. We cannot choose whether to prioritize. It happens anyway. Without clear principles for how the priorities are to take place, the offer to patients could be random and thus unfair. The goals of Nye Metoder. The main goal of the establishment was to make systematic use of health technology assessment to inform decision-making, to enhance patient safety by ensuring that patients have equal access to new methods that are proven to be effective while also meeting safety and cost-effective requirements, to ensure that effective and/or harmful new methods are not introduced and that obsolete health technologies are decommissioned, to provide an appropriate decision-making platform for priority setting based on health technology assessments, to ensure rational use of resources, and establish a systematic and predictable process for the introduction of new methods. A broad definition of methods. In this system, a method of health technology is defined as any method that can be used to prevent a disease, diagnose, or treat a patient. The system also covers rehabilitation methods, as well as various models for the organizational structure of the services provided by the specialist healthcare. Medicines, medical devices, and medical and surgical procedures are examples of methods covered by this broad definition. 3 categories of health technology assessments in Norway. In Norway, there are 3 health technology assessment formats: mini health technology assessment, single technology assessments, and full health technology assessments. Mini health technology assessments are brief assessments conducted by clinicians and support staff. The single technology assessments are performed by either the Norwegian Medicines Agency, if the method is a medicine, or the Norwegian Institute of Public Health for most other methods, and they focus on a single method of health technology. The Norwegian Institute of Public Health conducts full health technology assessment at the national level. For the example, the full health technology assessment could be used to compare various methods that have been used in clinical practice for some time. When assessing, the Norwegian Medicines Agency or the Norwegian Institute of Public Health collaborates closely with clinicians recruited by the 4 regional health authorities. The Norwegian Radiation Protection Authority contributes to the national and local health technology assessments involving medical radiation. Many participants in the system and broad cooperation. The Ministry of Health and Care Services was initially the owner of the system, but transferred the ownership to the regional health authorities. The Storting have from the 1st of January 2020 decided to legislate that the regional health authorities shall provide a common system for deciding which method can be offered in the specialist health service. At the same time, it was decided to include a clarification of the 3 prioritization criteria in the legislation. New methods is based on broad cooperation between the 4 regional health authorities, the Southeastern Regional Health Authority, the Western Regional Health Authority, the Northern Regional Health Authority, and the Central Regional Health Authority, including all the hospitals, and also the Hospital Procurement Trust, the Norwegian Institute of Public Health, the Norwegian Medicines Agency, the Norwegian Directorate of Health, and the Norwegian Radiation Protection Authority. In addition, there is a broad stakeholder group consisting of representatives from patient organizations, industry, professional associations, and universities to contribute to the development of the system. There are also regular dialogue meetings with industry associations in the pharmaceutical, medical device, and laboratory fields. The process. New metoder has two levels. The national level, where decisions are made based on health technologies assessment by the 4 regional health authorities in cooperation, and the local hospital level, where decisions are made based on many health technology assessments performed locally at each hospital. The type of method and its intended area of application direct the appropriate level of assessment. Certain methods, such as drugs, must always be processed through the national system. Simply put, both levels in the process are made up of the following major steps: proposal or horizon scanning, health technology assessment, priority setting decisions, and implementation. Proposals and horizon scanning reports complement one another and provide new methods to the system. Proposal for single technology assessments and health technology assessments are open to everyone in the specialist healthcare, patient and patients' organizations, industry, authorities, and the public. Most assessments are generated by the horizon scanning function. Employees in a specialist healthcare can start many health technology assessments at their hospital. The commissioning forum, comprised of the 4 medical directors, 1 from each regional health authority, and 2 delegates from the Norwegian Directorate of Health, has a mandate to prioritize the single technology assessments and the health technology assessments to be carried out based on the submitted proposals and horizon scanning reports. To improve the process of introducing new medicines, it has been decided to conduct single technology assessments on all new drugs and indications. There are different levels of assessment that are often related to the procurement process. As a result, the system has improved predictability, and the goal is to complete single technology assessment reports as close to the marketing authorization as possible. Following the completion of a single technology assessment, the Norwegian Hospital Procurement Trust conducts price negotiations. When the assessment and price negotiations are concluded, the regional health authorities then prepare cases to be submitted to the decision forum for new methods. Decision forum, comprised of the 4 CEOs, 1 from each regional health authority, decides whether or not to implement the method in the specialist health service. Decisions are made by consensus between the 4 CEOs. Also present in the meetings are an observer from the user committees and the health director, the 4 medical directors from the regional health authorities, and their secretariat, and the secretariat for new methods, and when relevant, assistance from the Norwegian Medicines Agency and the National Institute of Public Health. The Norwegian Directorate of Health is in charge of developing national clinical guidelines. When a decision is made on a method that is subject to a national guideline, the decisions made at the national level must be implemented in the guidelines. Concerning the priority setting criteria. Priority setting principles ensure that all patient groups in healthcare services have equal access to treatment. These principles must be founded on values that have widespread acceptance among the public and healthcare workers. In the discussion of the principles for priority setting, one can distinguish between different types of decision-making. Decision-making at the clinical level, at the group level, at the administrative level, and at the political level. In Nye Metoder, all decision-making is at group level and is about distribution of resources within a fixed budget set by the politicians. This means, in effect, that there can be no winners without losers, so to speak. If we use more resources on some patients, there will be less for others. Increasing the healthcare budget is a political decision only. Interventions in healthcare services are prioritized using the three criteria: the benefit criterion, the resource criterion, and the severity criterion. The benefit criterion and the severity criterion have been provided in two forms: a textual description for clinical use and a quantitative form for use in group health technology assessment. Because we only make decisions at group level in the national system, we'll only refer to the quantitative form in the following. The benefit criterion. The priority of an intervention increases in keeping with the expected benefit of the intervention. The benefit is measured in healthy life years. The resource criterion. The fewer resources an intervention requires, the greater the priority of this intervention. The severity criterion. The priority of an intervention increases in keeping with the severity of the condition. Severity is to be quantified as the number of healthy life years lost without the treatment under consideration, that is, absolute shortfall. Quality-adjusted life years, that is QALYs, is used as a measure of a healthy life year. The criteria are balanced as follows. The priority-setting criteria are assessed and weighted against one another. The greater the severity of the condition or the greater the benefit of the intervention, the more acceptable higher resource use will be. Prioritizing conditions with low severity and interventions with limited benefit, on the other hand, can only be justified if resource use is low. An intervention is weighted against the opportunity cost, or the benefit to other patients that could have been realized with the same resources. The cost-effectiveness ratio is calculated and compared to the opportunity cost. The cost-effectiveness ratio is to be weighted with the severity of the condition. To be funded by public healthcare, the intervention must provide more benefit per Norwegian krone, adjusted for severity, than the resources it displaces. Discretionary assessments. In context with the health technology assessments, discretionary assessments are to be included in the overall assessments of interventions by the decision forum. This applies in particular to assessments of the documentation quality and uncertainties, and also the overall budget impact of an intervention. Uncertainty. If all other factors are essentially equal, high uncertainty in documentation and calculation methods will result in lower priority. This means that it is legitimate to have a lower willingness to pay if there is poor documentation. Budget impact. In the event of significant budgetary effects, the opportunity cost will be high, that is measured as lost benefit. This can result in a lower willingness to pay. The argument is that if more than one existing treatment is displaced to finance a new one, the new method must replace the total health gain lost by disinvesting in existing measures. This should also affect the upper limit for willingness to pay if it is assumed that the subsequent measures that are displaced are more cost-effective than the first. When the introduction of a new method has significant budget impact, that implies that a disproportionate share of healthcare funds is allocated to just one treatment. Particularly small patient groups with extremely severe conditions. There are a significantly higher willingness to pay for particularly small patient groups with extremely severe conditions. There are 3 guiding criteria, all of which must be satisfied for methods to qualify for the scheme for particularly small patient groups with extremely severe conditions. 1. Group size is not to exceed about 1 patient per 100,000 inhabitants worldwide per method, that is prevalence, and less than about 50 patients in Norway per method in steady state. 2. Severity measured by absolute shortfall is to be a minimum of approximately 30 good life years lost. And 3. The method is expected to provide a significant benefit, that is a minimum of approximately 2 good life years gained compared to using standard treatment. When deciding to introduce the method, the authorities will often require that the method be monitored and is followed up, and that financing can be terminated if follow-up data is not satisfactory. Determination of start and stop criteria is included in deciding whether the method is to be used. Exceptions. There are no rules without exceptions. The general rule is that new methods should not be taken into use before they are assessed and a decision has been reached, either locally or nationally. Exceptions can, however, be justified in some circumstances. In new metoder, there are procedures for extraordinary usage of methods that are being evaluated before a decision is taken. This can be done on an individual level by the hospital treating the patient, or on a group level, nationally, by the 4 regional medical directors. It must be kept in mind that before an assessment and decision, most methods are not available at a negotiated price and are rarely expected to be cost-effective. The purpose of the system for new methods is to ensure equal and knowledge-based services to all patients, regardless of geography. This will be undermined if health personnel make individual assessments in violation of decisions made in the system for new methods that apply to the entire specialist health service. If the specialists of a health profession make individual assessments in violation of decisions made within the system for new methods, it can lead to unequal service and a less fair distribution of health resources. Finally, I'll give you a short introduction to our website, nymetoder.no, which unfortunately is in Norwegian only. We do have a search function at the top, but be aware that if you search for a specific drug, the spelling has to match the spelling used on the website. Under News, you'll find information about the upcoming meetings, the decisions, and the protocols are published shortly after the meetings. New Metoder has a high level of transparency. Basically, the only information that is not subject to public disclosure is price discounts, and that is a demand from the industry that we are required by law to comply with. I hope you have found this presentation helpful. The transcript of the presentation in a PDF file is made available together with the presentation. If you have questions related to Nye Metoder, you are welcome to send us an email. Thank you very much for your attention.